Okay, let's learn about a couple of disorders that are related to your erythrocytes. And the first is something I alluded to with erythropoietin, and that is a disease known as anemia. So anemia is when you have one of two different conditions. One is a shortage of red blood cells. So say you don't have 40 to 45% red blood cells in your blood. Say you only have 25% red blood cells and 75% plasma. That would be one type of anemia. The other broad category of anemia is you have a normal amount of red blood cells, but you don't have normal hemoglobin. Okay. So there are many different types of hemoglobin, but the whole point, sorry, there are many different types of anemia, but the point with having an abnormal amount, an abnormal hemoglobin is you would still have a decrease in the oxygen carrying capacity. So either you have decreased oxygen carrying capacity from not having enough red blood cells or from not having enough normal hemoglobin. So regardless of what is causing your anemia, you're going to feel tired because anytime you're trying to do any physical activity, you don't have the oxygen that you need. All right. Now, here in the United States, the most common cause of anemia is an iron deficiency anemia. It's a dietary thing. Okay. And in iron deficiency anemia, we have very small pale red blood cells. So on the left, you have normal red blood cells. And on the right, you can see that a lot of these cells are smaller than the ones on the left. But what you really see is that the middle of these cells are paler. And that's because there's no iron attached to that heme molecule. Okay. So women are much more prone to being iron deficient, and that's because of their menstrual periods where they are losing blood. If you're losing blood, then you cannot recycle that iron in your red blood cells because you don't have those red blood cells to recycle. The other group of people that have iron deficiency anemia are small children in the transition from baby food to adult food because babies don't like the foods that have iron in them when we transition them to adult food. And look at the food that we give to our children. Like, how much iron do you think there is in a Happy Meal from McDonald's? Okay. How many 2 and 3-year-olds are asking for spinach? How many are for steak? No, they're not asking for good nutrition. So as a parent, we have to be the ones to pay attention to what we are giving our children. So this can be diagnosed, obviously, with blood tests and seeing your healthcare providers, but there's a couple of clues that if you think you might be iron deficiency, you can look at your nail beds and compare them to nail beds of your friends. When you push on your nail beds, do they blanch or are they pretty pale? And there's not much blanching. Or the other thing is, look at your eye and look at your conjunctiva. How pale is it versus how pink it is compared to somebody else of your same skin tone, somebody else in your family? All right. Another really important disease is sickle cell. And with sickle cell, we have sickle cell disease and sickle cell trait. And the problem with sickle cell is a 1 amino acid chain, the 6th one on only one of those globin chains. Okay, it's the beta chain and it's the 6th amino acid, but you don't need to know that. But what happens is glutamic acid has been changed to a valine. That's all that has changed. but that is a huge change. Okay. Doesn't kill you outright, but it totally changes the oxygen carrying capacity of this hemoglobin molecule. And this is something that is inherited as an autosomal recessive disease. What that means is if you have this from one parent, you are a carrier, and you have the trait, and you can pass it on to your children. But if you have two copies of the genes, that means both of your parents were carriers. You had a 25% chance of getting it from both parents, and now you have the disease. So if both parents are carriers, they have 25% chance of a child not getting the gene, 50% chance of their children getting one copy of the gene, and 25% chance of a child getting the disease. Whereas if only one parent is a carrier, then 50% of their children would be carriers and 50% of their children will not be carriers. So here's the problem with sickle cell, the disease. This hemoglobin, which we call hemoglobin S, promotes the red blood cell to sickle. So do you see these red blood cells here that are not biconcave in shape? These are sickled cells. That's where the disease gets its name. And so this sickled cell has a lifespan of less than 90 days. So here's a typical sickle cell. And when we look at blood smears of people with sickle cells, we can see red blood cells that still have nuclei in them. And that's because the red bone marrow is kicking out immature red blood cells while they still have nuclei. Okay, so these red blood cells, yeah, they're red blood cells, but like, look, 70% of the cells are nuclei. It can't carry nearly the amount of oxygen. So this red blood cell is not doing the job of a normal red blood cell. Now, in addition, these sickled cells, and you can see there's quite a few sickled cells in this blood smear, these sickled cells rupture as they go through capillaries, and when they get to a fork in the road, they get stuck. Okay, they're not flexible. Remember, it was that biconcave shape that made them very flexible. These are rigid. That's why they rupture and break, and you have bleeding. And they also, if they don't rupture and break, then they get stuck. It's like having an accident on Highway 10 or the 405, and you have a clot now stopping blood flow, which is a bad thing. So when we look at where in the world we have lots of sickle cell disease, what you could notice, the percent of the population that has the sickle cell gene, there's a huge incidence here in Africa below the Sahara Desert, what's called sub-Saharan Africa, areas where 12 to 15% of the population has this gene, as well as here in India. And if we compare this to parts of the world where malaria is endemic, you'll see they match up. And when you see this, you should be pausing and asking yourself, why? And there's a very good reason. Malaria is an organism that when it's, carried and you get it, when that mosquito bites you and the organism gets in your blood, it lives in your red blood cell. But it cannot live in a sickled red blood cell. So it can't invade a sickled red blood cell. So if you're a child with sickle cell, you don't get malaria. So you live to reproductive age. But if you're a child without sickle cell, you have a much higher chance of dying in your childhood. And so that's why the population has a higher incidence of sickle cell disease in these parts of the world. Now, I want you to realize over 350,000 deaths per year are from sickle cell disease. So sickle cell does kill you. And sickle cell is a disease that we have here in the United States. We have over 100,000 people with the disease here in the United States. Yes, there is a lot in the South of the United States because there are a lot of Black people in the South of the United States. But look here in California, we don't have a big Black population. What do we have here? Think about that for a second. We know in the United States, sickle cell disease occurs in 1 in 365 Black or African American births. And that's because the trait is 1 in 13 babies. So when Black Americans get married in the United States and they're planning on having babies and they have the insurance, they usually get tested to see if they have the trait. So they know whether or not they're going to be passing on sickle cell disease. Now, here in California and in Texas, we have a big Hispanic population. And 1 out of 16,000 Hispanic Americans are born with the disease, and 7 per 1,000 births have the trait. So we have lots of sickle cell disease here in California. Okay. If we look at the survival of sickle cell in the United States, what you would notice, even as late as 1960, the life expectancy was elementary school when the life expectancy for all Americans was 70. Okay. As late as 1980, the life expectancy was around high school graduation, freshman year of college. Since then, with a lot of brand new medications and new treatments for sickle cell, we now have a life expectancy of around age 55 to 60 with treatment, if you have insurance and you can get all the treatment. And I need you to realize that even with maximum treatment with sickle cell disease, this is still a 20-year age gap, shorter than the normal life expectancy. And I also want you to realize that over half of the population in the United States with sickle cell disease are covered by Medicare, or the equivalent in childhood population. And whether or not you're covered by Medicare, the amount of income you have, whether it is the poverty level, or twice the poverty level, or 3 times the poverty level, depends on the state you are at. So in some states, like California, you could have 3 times the poverty level and qualify, whereas other states, you cannot. You have to have only twice the poverty level or only the poverty level. So where you live and where you're born directly affects your survival with the disease. Now, overall, if we look at the United States, we have about a 94% childhood survival now for sickle cell. That's childhood. It's not great, but it's still childhood. The UK has about 99% survival. Jamaica has about 84%. And Africa has about a 10%. But there's a note I want to say, and that is a survival rate. That 10% is for rural African children. Then that's because rural African children don't have access to treatment. Whereas if you are an African child who lives in a major urban area and your family has the money to purchase care, and that's a big and, then your survival rate would be closer to 50%. But if you are an African child who lives in a major urban area, but you don't have the money to buy medical care, you still are going to fall in that 10% survival rate. All right. The next thing I want to talk about, and the last thing, is going to be blood doping. And blood doping is any method of increasing the normal supply of red blood cells for the purpose of delivering oxygen to reduce fatigue and give a competitive edge. Okay. This was a big problem for about 25 years. There's been a lot of testing done for blood doping. And so let me tell you, like, the 3 most common things that used to be done for doping. And it used to be like all steroid related. And then once we found out about erythropoietin and we could make fake erythropoietin, that came into play. And so what came into play was people would inject themselves with erythropoietin months before the competition. So you would have a lot more red blood cells. Don't ask me why the red blood cells are blue in this picture, but I thought it was a really good picture. So you would increase your number of red blood cells. But like I said, they did this months before the competition. And the reason was because they could remove up to 4 units of their blood. So they could be doing this months and months and months before the big competition, before the Olympics, before the Tour de France, before whatever it is. They would remove the blood and centrifuge it, okay, to concentrate the red blood cells. And that's because packed red blood cells can be stored 6 weeks under refrigeration. They will last 6 weeks. And then you can give it to the person the week before the competition. And now they have a much higher than 45% red blood cells in their blood. A second way of blood doping would be the person could train at altitude and remove their blood. So you wouldn't be giving them fake EPO, they would be generating their own EPO. Okay. But once again, you would remove their own blood, make packed red blood cells, and reinfuse them later. And the third thing would be you could transfuse with someone else's bloods. Okay. So why do we have so much anti-doping? Because with transfusion, the percent red blood cell would rise to about 55% of your blood. And then after exercise, you would become dehydrated, even though you're drinking. So then this would raise even higher. And so now your body, your blood has turned to like sludge. And so you can imagine the sludge has difficulty getting through all the nooks and crannies in your body. And so this led to strokes and heart attacks and even deaths in some of our best athletes. Excuse me. And one of the sports that this was known to have happened to was in the Tour de France. So much that people made signs and called it the Tour de Doping. And so we had anti-doping tests. So we started testing in order for the blood, the packed cells, not to clot. There is stuff put in that. So the first things that happen is you can test for the presence of that citric acid and other things that keep the blood from clotting. We can test blood levels of erythropoietin. Okay. So what happened was the number of positive tested cycling by year went down, but we still know that there was doping going on. And we still know that there is doping going on because as records keep on falling, if shoes and bikes and other, clothing and other things haven't changed, then something is happening and we haven't caught it yet. So one thing that really changed was they started testing out of competition, because it's that out of competition testing that could catch high EPO levels. Okay. And so this is why anti-doping has become a real force in competition worldwide. And we know competitions aren't clean, but I'm just going to leave it at that for now. And thank you so much. And we're going to come back and talk about your white blood cells in the next section.